Imagine a country that decided every single citizen, regardless of income, regardless of location, regardless of status, deserves free healthcare. And then actually built it. That country is Brazil. And on day 13 of documenting my rise as a global health and wealth architect, living and practicing medicine in Brazil as a Ghanaian doctor, I want to take you inside the Sistema Único de Saúde, the SUS, Brazil's unified public health system. Because I believe Africa is missing one of the most important public health case studies available to it right now. And I have seen it from the inside. What SUS actually is. The SUS, Sistema Único de Saúde, was born in 1988 from Brazil's new democratic constitution. After decades of military dictatorship, the Brazilian people declared something radical, that health is a right of every citizen and a duty of the state. Not a privilege, not a commodity, a right. What emerged was one of the largest and most ambitious public health systems ever constructed anywhere in the world. Today SUS serves over 200 million people. It provides free consultations, free hospitalization, free surgery, free medication, free vaccines, free prenatal care and free cancer treatment to every Brazilian citizen who needs it. The Family Health Strategy, one of SUS's most celebrated innovations, deploys community health teams directly into neighborhoods. Each team covers a defined geographic area. They know the families. They visit the homes. They identify health problems before they become emergencies. This is the closest thing to direct primary care that any public system has ever attempted at national scale. And it works, in ways that global health experts are still studying decades later. What Africa must learn from SUS. I want to speak directly to every young health leader, policymaker and public health student in Africa watching this. There are lessons inside the SUS model that are directly transferable to the African context, and they are not being discussed loudly enough. Lesson 1. The constitutional right. Brazil embedded health as a constitutional right. Not a government program, not a policy that changes with each election. A right, enshrined in law. Africa's health systems will never achieve stability until health is treated as a non-negotiable constitutional guarantee, not a political bargaining chip. Lesson 2. Community health workers. SUS's Community Health Worker program is one of the most successful in human history. Trained local people, from the communities they serve, delivering basic health services, health education and referrals directly into homes. This model is replicable across every African nation. It does not require massive hospital infrastructure. It requires investment in people. Lesson 3. Decentralization. SUS distributes health governance across federal, state and municipal levels. Local governments manage local health needs. This decentralization has allowed health innovations to emerge at community level and scale upward, rather than waiting for a national government to design solutions from the top down. Africa's highly centralized health systems could transform with this approach. Lesson 4. Health as economic policy. Brazil understood that a sick population cannot build a productive economy. Investing in SUS was not charity, it was economic architecture. African governments that treat health investment as expenditure rather than infrastructure are making a category error that compounds with every generation. Where SUS falls short, the honest assessment. Now let me give you the honest picture. Because as someone practicing medicine inside Brazil, I have seen both the brilliance and the fractures of this system from the examination room. The funding crisis. SUS is chronically underfunded. Despite constitutional guarantees, political priorities have repeatedly squeezed health budgets. The result is a system that promises everything and sometimes delivers far less. Wait times for specialist appointments can stretch to months. Diagnostic equipment sits broken in clinics without maintenance budgets. Nurses and doctors work in conditions that would be considered unacceptable in private facilities a few kilometers away. The inequality gap. Brazil has one of the most dramatic health inequality stories in the world. SUS serves the public, and then there is the private health system, operated by insurance companies and private hospitals, that serves those who can afford it. The gap between these two systems in quality, speed and outcomes is one of the starkest health equity failures in any country calling itself democratic. The racial dimension. Black Brazilians, who disproportionately rely on SUS, experience dramatically worse health outcomes than white Brazilians across almost every indicator. Maternal mortality, cancer survival, chronic disease management. The system that was designed to serve everyone serves some people far less well than others. This is not a funding problem alone. It is a structural racism problem embedded in the architecture of care delivery. The primary care gap. Despite the family health strategy, vast regions of Brazil, particularly in the Amazon and the rural Northeast, remain severely underserved. Telemedicine has begun to fill some of this gap, but the promise of universal coverage still outpaces the reality of universal access. What this means for the global health architect. I did not come to Brazil as a tourist. I came as a student of health systems. And what I have learned inside SUS, both its extraordinary ambition and its very human failures, has fundamentally shaped my vision for what health architecture in Africa can and must look like. Africa does not need to copy SUS. Africa needs to learn from it and build better. Build systems that constitutionally protect the right to health. Build community health worker programs that reach the family before the crisis arrives. Build decentralized health governance that trusts local communities to solve local problems. Build funding models that treat health investment as economic infrastructure, not charity. And critically, build systems that see the racial, gender and geographic inequalities that formal universal systems so often hide behind the word universal. This is what a global health architect does. Not just study systems, design better ones. And I am documenting every step of learning what better looks like, for Africa, for Brazil, and for the world. If this opened your eyes to a health system you had never studied, share it with someone building in the public health space. Subscribe, comment below. Does your country have universal health coverage? And is it working?